Hello everybody, it's Dr. Ermias here with another video. I am a board certified internist practicing here in the United States. I have a YouTube channel called Smarthospitalist where I try to upload videos regarding updates in hospital medicine and mostly challenging old outdated practices that we still adhere to in our medical practice. If you like that kind of stuff, please subscribe to my channel. I hope you will find it useful. Today, I come to you with an interesting and often challenging topic that I face in my day-to-day practice. It is about medication allergies. Here in the United States, we use an electronic medical record system, right? So on the top corner of the chart, you will have a section for allergies. And when you click on that, in most patients, you will see a drop-down list of medications and food items that they're allergic to. Sometimes you get really amazed as how can somebody be allergic to all these medications and food items, right? Um, but are they really allergic to these medications? I mean, who knows, right? Mostly, probably no. Amongst medications that are included in these allergy lists, penicillins are the most common. So my today's talk is about penicillin allergy and how we should approach it. And uh, is it real or is it real myth? So just gonna go into the evidence. The reason why I wanted to do this video today is because I had a patient today who came with cellulitis to the hospital, and in her allergies, penicillin was listed. Caflex, which is cephalexin, is listed. Bactrim is listed. So all the good antibiotics that we can use to treat a simple cellulitis, they are listed as allergies. And for this patient with no other complications, from the cellulitis, you'll be obliged you you'll be obliged to use other more expensive and more toxic medications like vancomycin, right? So but was she really allergic to these medications? And even if she was allergic, could we still have went ahead and used the penicillins or cephalosporins in her case? So without further ado, I'll just go into the presentation. All right, so why does this matter? Well, some of it I already discussed it, right? But the most important thing is penicillin allergy is commonly reported. Up to 10% of the US population, believe it or not, reports penicillin allergy. But studies have shown that more than 95% of these reported allergies are actually not true allergies. So the, the fact that these are listed as allergies, leads to broader antibiotic use, antibiotic resistance, and worse outcomes because of using less efficacious antibiotics for their conditions. So usually a penicillin allergy label is given during childhood, right? And according to this New England Journal of Medicine study, up to 20% of the population, can report penicillin allergies. And this had its own personal health implications, public health implications, uh, you know, uh, in terms of using appropriate antibiotics, the rational use of antibiotics. But with formal allergy assessment, you can only confirm less than 5% of these allergies. So why the discrepancy? It's because many original reactions were not really immunologic. These were during childhood, back in the 60s, 70s, viral exanthems, GI intolerance, drug and infection interactions, all these were blamed on the antibiotics, and people said that they are allergic to penicillin. And also additionally, IgE-mediated penicillin allergies, they wean over time, with approximately 80% of patients losing their sensitivity after 10 years. So the fact that you've been allergic 20 years ago does not necessarily mean that you're still allergic to the penicillin. And also sometimes side effects like GI intolerance, headache, these are documented as allergy, which are really not allergies. And then once somebody has a penicillin allergy label, it will never be taken away. It will never be reevaluated. So they will always be labeled as penicillin allergies. Sometimes you find patients who are labeled as penicillin allergy, but they tell you that, well, I took amoxicillin for this infection, but nobody goes back and clears that penicillin allergy from their list. So what is a true penicillin allergy? So true penicillin allergy is mediated by two mechanisms, right? The first one and the most, feared complication is the IgE-mediated penicillin complication, which usually mediates immediately within a few hours, including like angioedema, anaphylaxis, bronchospasm, which is life-threatening, or urticaria, right? So this can be confirmed through skin testing. The second one is a T-cell mediated delayed reaction. They usually occur days after exposure and usually include cutaneous manifestations, including rashes. And these ones are not cannot be tested with the skin testing because they do not reliably recur with re-challenge. So these are the only true penicillin allergies. Otherwise, you took a penicillin and you had a headache and nausea and vomiting. That's not really allergy. So then the next question that comes is, in people who are penicillin allergic, can we use some types of penicillins or encephalosporins, and what is the cross reactivity if there's a true penicillin allergy? So all studies suggested that there could be up to 10% cross reactivity between penicillins and cephalosporins. But this was later rebuked because modern data showed that this is overestimated or overstated, and the rate is usually 1 to 3%. And the reason being, back in the 1980s, most cephalosporins during their preparation were contaminated with penicillins. So a recent study showed it's 1 to 3%. Especially in patients with non-confirmed, non-anaphylactic penicillin allergies, the cross-reactivity with cephalosporins is less than 0.1%. So previously it was thought that this was due to the beta-lactam ring, but recent studies have shown that it's oftentimes this is not a reaction due for the beta-lactam ring. It's rather a reaction to the side chains to the beta-lactam ring. So which cephalosporins are safer? So in general, second to fifth generation cephalosporins have very minimal cross-reactivity whatsoever between with penicillins. So in most patients with penicillin allergy, like I'm talking about true penicillin allergy, ceftriaxone, cefepime, these are generally safe. You can avoid them only if patients have prior severe IgE reaction. In these patients, you might need to do some sensitivity testing, skin testing. Cefazolin, which we call here Ancef in a brand name, despite being a first generation cephalosporin, it has a very unique side chain and it has a very low cross reactivity with penicillin. So this has been, there are multiple studies confirming this. So cefazolin can be used safely in patients with penicillin allergy, despite being a first generation cephalosporin. So the highest cross reaction occurs between amino cephalosporins. These are like cefalexin, cefaclor. These are like first generation oral cephalosporins. This demonstrate a very high cross reactivity because they have a very similar or identical R1 side chain with the aminopenicillins like amoxicillin and ampicillin. So these ones you kind of have to avoid. But in general, next about carbapenems. Carbapenems are usually safe in patients with either penicillin or cephalosporin allergies. And they can be administered without testing or additional precautions, regardless of whether the reaction was anaphylactic or not. So you can safely use your meropenem, imipenem, or tapenem in patients with even true anaphylactic allergies to penicillin. They can still be used. Aztreonam has been the drug of choice for penicillin allergic patients for a long time now. An expensive medication, not really a good one in terms of efficacy, but it can be used in all penicillin allergic patients, except in those patients with ceftazidime allergy, because aztreonam and ceftazidime share a similar side chain. But in general, the American Academy of Allergy uh, recommends uh, for patients with a history of unverified non-anaphylactic penicillin allergy, any cephalosporins can be administered routinely without any testing or additional precautions. And for those rare patients with a history of anaphylaxis to penicillin, a non-cross-reactive cephalosporin, like for example cefazolin, as we said earlier, right, can be administered routinely without prior testing. Most of my talk, by the way, is based on this recommendation from American Academy of Allergy. This came out recently. This was revised, I think, in 2022. So you can refer that for further information. Uh, so everybody is aware of this chart of cross-reactivity between the different beta-lactam agents. It looks busy, but it's kind of easy to read, and it shows you which beta-lactam antibiotic actually has a similar side chain and kind of cross-reacts. So I mean, you can see here that cefazolin, where cefazolin, look, it can be given to any patient with allergy to any of the penicillins or the cephalosporins. I mean, yeah, you can just pause the video or download this chart and look at it yourself. It's really helpful. So now I want to talk about benefits of delabeling penicillin allergy. So if most penicillin allergies are not really true allergies, then we should delabel the penicillin allergy, right? This would be really helpful. One, it makes our life much easier because we can give the first line antibiotic regimen for any of the infection that the patients could be having. So that's better antibiotic selection in terms of cost as well, and lower C. diff and resistance because you're not going to use broader antibiotics, right? Shorter lengths of stay in the hospital because you are using the right antibiotic, and lower mortality in the grand scheme of things, right? So how can we go ahead and delabel penicillin allergy in our patients? So they came up with this score called PENFAST, Penicillin Allergy Clinical Decision Rule. This is a score that you can use to select patients who are at a really a high risk or a low risk for a true penicillin allergy. So you can pause the video and take a look at the score here. So if the PENFAST score is greater than 3, which means the patient's at a high risk for penicillin allergy, these are patients who have experienced an IgE-mediated anaphylaxis or urticaria recently. Then for these patients, you need to do penicillin skin testing, and this can be followed by a direct challenge test in the hospital. So penicillin skin testing checks for the IgE-mediated reactions. And there are some minor reactions which cannot be detected by the penicillin skin test. Therefore, that needs to be followed by a direct antibiotic challenge observed. If this is negative, then the likelihood of having a significant reaction to a penicillin or cephalosporin in the future is very low. For patients who have remote and benign reported allergy, that usually a PENFAST score of less than 3, these patients do not need penicillin skin testing. You can actually just go ahead and directly challenge them with a penicillin antibiotic. Mostly we use amoxicillin for this, without any preceding skin testing, and this has been proven to be very compatible to penicillin skin testing followed by direct challenge. So, and it makes your life much easier. It can be done in the inpatient or outpatient setup. In those patients with histories which are not inconsistent with allergies, those patients reporting like headache, nausea, and vomiting after they received penicillin, these do not need any testing. They can be delabeled right away. But sometimes these patients, they have anxiety, and then they want some confirmation. So, in these patients, again, you might do direct challenge testing and show them that it's okay to take the penicillin. So what is a recommended direct challenge protocol? This has been proven, right? So there is this study called the PALACE study, which is a randomized controlled trial, which said that direct oral challenge is non-inferior to skin testing followed by direct challenge in low risk patients. So there are different protocols, but a common protocol include either a one-stage approach where you just give them like 250 to 500 milligrams of amoxicillin and observe them for a few hours afterwards, or in patients who are at a slightly higher risk, you can use a two-step approach where you first give them 50 milligrams of amoxicillin and then follow that up by 500 milligrams in an hour and see if there are any reactions. So the key take-home points from this presentation is that most penicillin allergies are inaccurate. More than 95% of penicillin allergies are not true penicillin allergies. And the cross-reactivity with cephalosporins and carbapenems is very low, so you should be able to use those antibiotics in these patients. And in general, the history and evidence should guide therapy, and we should, as much as possible, try to delabel penicillin allergies. I guess this would probably take an initiative in the hospital with a multidisciplinary team from pharmacists, infectious disease specialists, and physicians coming together, and setting up some sort of a protocol where patients are delabeled from their penicillin allergies. So we, should be able to use penicillins in these patients. Thank you for watching the video. If you have any questions and comments, please leave them in the comment section. I will read and get back to you. If you like the contents of this video and the contents of my channel in general, please subscribe to the channel and hit the like button. Until my next video,